for this today's smart learning webinar on clinical research and biostatistics. Um, Many urologists, many clinicians and postgraduates, they find research methodology and biostatistics a difficult subject. Terms like confidence intervals, p-values, study design, bias, these terms appear complex and intimidating. But these are indispensable tools for every modern urologist, not only for conducting research, but also for critically evaluating the medical literature that influences our daily practice. So recognizing this need, the Indian School of Urology has initiated this webinar to simplify these concepts and make them relevant to day-to-day urology practice. I thank Dr. Abhijit Patil, who is the convener for this webinar, who is the right person to do this webinar. And he has selected the excellent faculty. We have Dr. Ravi Mohan, Dr. Aditya Prakash, Dr. Arun Chawla, Dr. Ginil Kumar, Dr. Prashant Malavkar, Dr. Pankaj Maheshwari, and Dr. Vasudeva, biostatistician, who are the excellent, eminent faculty in this field, and they are going to share their knowledge with us. So I thank all the faculty for sparing their time, and I'm very confident that today's sessions will provide practical insights and equip all of us with the knowledge that can be applied to our day-to-day work. So I encourage all the participants to actively engage in the topic. And this learning research methodology is an investment, I can say, that will continue to benefit all of you throughout your professional career. So now we have with us Dr. Keshav Murthy sir, President, Urological Society of India, and we have Dr. Uttam Meter sir, who is Honorary Secretary of USI. Before we start the session, and I request Keshav Murthy sir to give his brief address.
Keshav Thank you, Suri. Can you hear me?
Yes, yes.
Yeah. Good evening, everybody, and welcome to this webinar on clinical research and biostatistics. As Surya Prakash has enumerated, that it's very an important topic, and I'm sure all the people who are ready to present their material today are well prepared. They're all stalwarts in publishing articles, so you will find it to be very useful. They'll give you tips about it, and important thing is to learn about biostatistics. It may be boring, but it's a very important topic which you need to do. And as you all know, we have the collaborative research committee, which is actually headed by Dr. Giril. He's also part of the faculty. The USI is focusing on promoting research in the Urological Society of India. So this would be an important webinar from that point of view. I hope this section will be interesting. Over to you, Dr. Suri.
Thank you, sir. Now, may I request Dr. Uttam Meter sir to give you a brief address?
Thank you, Dr. Surya Prakash. As a Secretary of the Urological Society of India, this has become a ritual only that I welcome everybody. But this evening, rather than only ritual, I would like to say something from my own experience. I am in the institute for decades together. I have been an examiner for so many places and for a faculty interview also. I have seen people perceive this research and statistics as a very complex procedure, but which is definitely not. And only thing that you need to develop some interest. Now, how to develop interest, that I don't know. The residents who are joining as MCHC, this is the highest degree. I don't find anything wrong with them. I think we don't have a proper curriculum during our MBBS. You see, everybody knows that during MBBS, during only community medicine, we read a little bit of statistics, then we forget everything. So we need to have, we need to have a proper curriculum. So it is not their fault. And definitely these are not complex situations. And for a better patient management also, we need to have a research, the outcome, but how to do a research and how to interpret that, that is the point. I think this is going to be discussed today. And I'm sure today's faculty will simplify in such a way, everybody will generate some interest for these things. And we see all the best. And of course, I must thank Surya Prakash as the ISU chairman and Abhijit Patil and all the faculty members and of course all the delegates. Thank you very much. Thanks a lot.
Thank you, sir. Thank you very much. Now I request Dr. Abhijit Patil, who is the convener of this webinar, to introduce the topic and then take it forward. Over to you, Dr. Abhijit.
Well, thank you, sir. Myself, Dr. Abhijit Patil, consultant urologist at Mujibhai Patel Urological Hospital, Nadiad. I will take this opportunity first to thank USI President Dr. Keshav Murthy sir, Secretary, Honorary Secretary Mete sir, whole council, and Dr. Surya Prakash sir to entitle me with this opportunity. So as sir said that many young urologists now are focusing on research. So when we think about research, we thought to have a very good webinar on clinical research and biostatistics. There are many young residents now, they just give their data to biostatistician and they don't know which test they apply or not apply. And nowadays, what people find it is the easiest way to feed everything to AI and get it out from AI. And mind you, all the AI that you use and the plagiarism that you use can be picked up by very good softwares in universities, and then you may land up in problem. So instead of using or finding shortcuts, we thought that let us have an in-depth knowledge about this field from the experts. As you can see from the webinar that we speakers that we have, everyone has a very good legacy of in publication in urology. They are peer reviewers, they have presented too many papers, they have done a lot of research. So without taking much time, we would like to start this webinar, and I would urge all the young urologists and especially the residents to please take good note of whatever the things they have, and they are free to ask any question in the chat box, and we will take the questions at the end of it. This is a webinar for you all, and be free to ask questions. Don't worry about whatsoever the silly question be, but we will get it cleared from the expert themselves. So with this, we will start a webinar. I would like to welcome the first speaker for this webinar, which is Dr. Ravi Mohan sir. He is professor of urology at PGI Chandigarh, and his topic is choosing the right research topic.
Thank
Over to
you.
you.
Yeah, thank you, Abhijit. Thank you, USI, ISU, for this opportunity. It's more than teaching; it's a learning for us, and it's a continuous process. So, as while I was preparing, I also learned certain things, and I'm sure during biostatistics we will learn more. The topic which was given to me was choosing a right question, and believe me, every strong study would actually begin with a good question. If you have a right question, you are half of the job is done. So what I have tried to cover in this session is uh, how should we build upon a question? What are with some examples during in urology, because it's a urology residents topic, and what are the common mistakes which one makes when they start? My idea is not to give you ideas of research question, because it is for your brain to think, for your curiosity to unravel. The only idea is to impress upon you how to select a right question. Now, having said that, I mean, the question drives every study decision. It's one great author said that a good question is half the answer. So if you believe me, this is the first step, and that's why rightly it is the first topic of discussion today. Because you poorly frame a question, the entire study gets derailed. It's like a wheel. The the research question is like a wheel, and for the wheel to be driving on its own, if you have all the spokes which are well attached, then you have a then the study automatically progresses. So spend some time, brainstorm this so that you reach to a right question. And the what are the spokes of the wheel? These are some pictorial representation, and you can keep on adding adjectives as you require. But something which I thought were relevant was it should be feasible. Yeah, obviously, it should be original. You cannot replicate something. Although research itself means that you are searching it again, but then it should not be like copy paste from some people in the last moment. They will ask for a topic and then prepare copy paste from others' research. That's not that it should not be. It should be relevant, it should be complex and arguable, it should be researchable, focused, and specific. Now let's discuss these terms in a little more detail. What are the traits of a strong research question? One, it should be clear. So you try to use a precise language. You cannot use, say, let's say you want to do a study on stone disease, and how do you assess the stone free rate? You cannot say successful treatment after PCNL. You have to mention that it is what you want to see, stone free rate, and at what time. You cannot say stone free rates. You have to mention at what time you want to. So it should be clear, and you must use a precise language when you want to generate a question. Then it should be focused. You cannot say compare 100 things, or you cannot put, see, a stone treatment. It has to be more focused, that if you want to compare ureteroscopy with shockwave, or let's say PCNL with ureteroscopy, or RRS with flexible, RRS with PCNL, it has to be a focused question. You have to define what you want to do. Then it should be researchable. It's not that you would have a vague question and there is no data on anywhere else, and then you end up with not finding a right answer. It should obviously feasible. Suppose the disease incidence is very low. Let's say you're working in studying in MPUH and you have a CA penis presentation very low. You cannot obviously do a research on CA penis. But whereas if you have a stone as a major bulk, you can do it. So it should be feasible that it matches your case volume and your time. It should be significant, something like it should change a practice, like a research which is rightly done and a right research would actually have an impact. I'll give a small example. Sometime a couple of decades back, we had a research where we tried to see in PJ, one of our senior colleagues, he saw the ounce-filled units of stone, does it predict DSWL? Very simple thing, but on a CT, and it was well appreciated, published, and it referred in Campbell. So it one can change the practice if you have the right kind of research. And obviously, it should be ethical. There should be, you cannot compare, when you're doing a comparative study, you cannot compare A with a non-standard of care. You always have to compare with the standard of care for that particular treatment against a new treatment. It should always be ethical. Now, let us see, where does a good question come from? Mm, uh, Research is what to see what everybody else has seen, but to think what nobody else has thought. That is what the research is, because it apparently everything is there in this world, but unless you are able to think differently, you will not be able to come out with a right question. So, very essential, dear residents, you must have the personal curiosity. That is something which is going to ignite. So, a good research question can be generated only by a very strong personal curiosity, and the curiosity of why it is happening, why these things happen the way, why do we do something the way we do. If your senior tells you to do something, if you don't question it, you will never be coming out with a research question. So, if you have noticed a pattern in your clinic or OR, simple recurrent stone formers who fail dietary counseling. Why do they fail? So this question would actually then lead on to researching what are the factors which responsible and things like that. Now, once you develop a curiosity, it is very essential that you find out, because already people would have studied that. So go into the literature, find out what already has been studied about it, so that your knowledge is clarified, and then you'd see what are the gaps. A simple thing like what is the optimal time of catheter removal after prostatectomy? Somebody would say 3 days, somebody would say 5 days, and you might have seen that if you remove it 3 days, it's a problem. So if with your curiosity, if you see what all things are published, then you find a right gap in the literature so that your research question can be generated. It should be based on real world problems. For example, failed hypospadias in adults. Everyone has seen that hypospadias surgery fails when is not as predictable as you do it in children. But then so that's the real world problem. So what are the solutions to it? Once you start thinking in those lines, you start refining your surgical technique and you start deciding, okay, this is what I want to see in a particular surgery. And in institute especially, it is true that if you already done a part of the work as a part of thesis of somebody, one student, you should build upon that. So every study would end up with say, let's say these were the lacunae of the study, and if you believe that the study was good, you can grow upon that, so extending your prior work. So from these things your questions would come up. And one simple way of structuring a question is the PICO, because you are anyway going to write your conduct and write your research paper eventually in the PICO format only. So it is simpler that you try to structure your research question in the PICO format whenever feasible. It will not be feasible in almost always, but it should be PICO in the PICO format, where it is population, who is being studied, what is the intervention, what are the comparators, and what are you measuring. Let's say, for the example, in a men with localized low risk prostate cancer, does active surveillance compared with immediate radical prostatectomy affect 10-year overall survival? If you see here you cover the entire PICO. Which patient? Low risk prostate cancer. What is the intervention? Active surveillance. What is the comparator? Radical prostate. And what is the outcome you want to see is the overall survival at 10 years. So this is a perfectly framed research question. Once you get to such a research question, your research would always merit a good, nice study and a nice publication eventually. Now, some helpful tips I think a lot of them will be covered in the other talks as well. And my only idea is to initiate you into that brainstorming or concept. So always, as I said, to begin with, keep on thinking, brainstorm. Once you have a query, you keep on discussing with your fellow colleagues, with your guides, with your teachers, with see the literature. So you should spend as much time here, because once you get a right topic, automatically everything moves in the right direction. And I had few seniors who used to write their research, because sometimes you have an idea but you don't remember subsequently. It's always better to write the research question which comes to your mind, and then keep on rephrasing it till you reach the right thing. And these research questions also determine the type of the study. Suppose you want to the whether it's an RCT or a case control or a cohort study, all of these studies which you will be covering in detail in biostatistics part, but the research question would actually determine what type of study it would be eventually. And some of the potential problems now one faces. This is from one Journal of Pediatrics, where I found a article in 2019 which mentioned how to write a research. Sometimes your question may be too broad, so ensure that the question should not be too broad. You should be as specific, like the prostate active surveillance we just saw. It may not have enough subjects. So how to circumvent that? You increase your inclusion criteria so that you have more subjects, and modify the exclusion so that you limit the exclusions. Then the methods are beyond your skill. Obviously, you should collaborate for such things. Sometimes you're doing some enzyme-based study or a marker-based study. It may be too expensive. It's always better to understand, to realize whatever expense you have. Sometimes you have various ICMR and DST projects where you can write up and get those gadgets to do it. And sometimes it may not be relevant. So for relevance, it is more important that you keep on discussing with your mentors and peers. Now, how do you reach a research question? First, you start with a broad topic, let's say prostate cancer. Then you narrow it to surgical approach to localize. Then you focus it, robotic versus open, and that's how you will generate a research question. So you always, it's a reverse pyramid, that you start from a broader area, keep on narrowing it, keep on making it focused, and then you get a research question, something like this: does robotic radical prostate improve a 12-month urinary continence compared with open surgery? Everything covered in this. Now, what are the types of research questions? Obviously, they could be qualitative. Suppose you're just trying to see the age difference, or what is the incidence of X disease in a particular population. Those will be kind of qualitative research questions. Sometimes the research question could be quantitative. You want to compare a numerical value of one versus the levels of, let's say, enzymes in one group versus the other. And the statistical research questions would be much more detailed out in the subsequent presentations. So common mistakes to avoid: don't make the question too broad. What are the effect of kidney stones? Cannot be answered in one study. Don't make it too narrow, like one surgeon's technique. Let's say I say PGI technique. That doesn't make any. That won't ever be generalized. So it could be good for a case report or a case series, but you really want to make an impact, you have to have a comparator with a standard of care. It should not be unanswerable. Like, is robotic surgery better than open surgery? Is meaningless unless it is you specifically say what in robotic surgery at what time and what are the outcomes. It could be it should not be biased, like why PSA screening unnecessary in older men. So the question itself is answering you, making you feel that okay, maybe it is not necessary. So ensure that these type of mistakes are not made in your generating the research question. And sometimes your research question will be purely descriptive. What percent of patients had complications? It has no meaning, because that's the statistical part. You want to see what is the complications of X procedure. Are they different over X period of time? Now, let's take an example. Now, this question: what are the effects of kidney stone on patients? Here you can see it doesn't have any defined population. It has vague outcome effects. There is no comparison group, and it is impossible to fully answer. So obviously, it's a weak question. On the other hand, among adults with symptomatic ureteric stones less than 10 millimeter, does tamsulosin increase stone passage rate within 4 weeks compared to observation alone? Everything well defined. So you have a population's intervention, comparison, and measurable outcome. So this is a strong question. So as I said, my aim was never to give you questions. My aim was always to bring you to a point where you start developing your question, and you have AI-based aids which can help you to generate good questions. Something like this can help you, that a checklist that whenever you have a research question, you can screen your question through these 5 or 6 checklists that can it be answered with the data I realistically collect. Is it focused on one clear comparison or outcome? Does it avoid assuming the answer in advance? Would the answer change the practice? Can I complete it with my time? And is IRB approval a no risk? So if you have yes to all these questions, probably your question is a right research question and it's a go ahead for the research. So with that, I think I'll leave some time for question and answers at the end. But the entire idea was that you start a broad, review the literature, then narrow relentlessly until the question is clear, focused, and answerable. Thank you.
Well, well, thank you, sir, for that wonderful insight of choosing the right topic. So what we have decided is choosing the right topic. Then let's have how to calculate the correct sample size. Then the biostatistics by Dr. Vasudeva, designing an RCT and understanding something about systemic analysis and meta-analysis. Then finally, we have to do something for bibliography and choosing the right journal to publish it. So we will call the next speaker. Let's have on biostatistics, which is needed for urologists. This is generally a topic which many urologists are worried about and they're afraid of understanding the biostatistics. We have Dr. Vasudeva sir, who is professor and head of biostatistics department at Manipal University, and he is MSc in biostatistics. We are privileged to have you, sir, over this, and I'd hand it over to you for this talk, sir.
Yeah, thank you, Dr. Abhijit. I'll share my screen.
Yes.
Yeah. So my screen visible?
Yes, sir. It's visible.
Visible. Yeah.
Okay.
So
Sir, right side will down, sir.
yeah, thank you. So good evening, everyone. My name is Vasudev. So I'll be just introducing the basic concepts of biostatistics for urologists. So contents are this: so common type of outcomes in urological research, and what are different types of outcome measures and summary measures we'll be using, and choosing appropriate statistical test and interpreting the effect size, the 95% confidence interval, and how to present the results. So these are the content. And learning objective, I'm having 2 objectives: to identify different types of variables, primary and secondary, used in urological research, and identify the appropriate statistical methods for common urological research questions. So I had some questions here. So the first question, if you see, we are comparing 2 different treatment regimens. Then second one, does PSA predict the prostate cancer? So which patient recur and which treatment has fewer complications? Now, if you see the outcome, so there are different types of outcome measures. So as the first speaker has mentioned, so we can have qualitative, quantitative research questions and all this. So here, any research question, if you see, we have the something called primary outcome measure. The outcome measure can be continuous. So the examples are PSA levels, age, stone size, and the duration. And second, it could be ordinal, something like a tumor stage or any kind of grades is there. So it's a categorical response. We can have it's an order in place, or binary response, maybe stone-free status yes and no, urinary incontinence this one present or absent, so prostate cancer yes and no, and it could be time to event. So we would like to see that recurrence-free survival, overall survival, and time to some recurrence of a disease it is. So if you see this research question, so we can have several primary outcome measures. So first one, when I looked into that, so I can have a primary outcome measure as catheterization duration, length of stay hospital, this one, IPSS improvement, maximum urinary flow rate. So these are all the continuous outcome variable I can have. Second, if I take histopathology, confirm prostate cancer, yes or no, this is the outcome variable. And biopsy positivity will be looking into. And which patient develop recurrence after radical prostatectomy, if you see, time to biochemical recurrence and disease-free survival or overall survival. So this is a continuous outcome variable where where it is measured in time. And which treatment has fewer complications. So it's a binary outcome variable. We'll be looking into overall complication rate, or maybe some kind of grades or emission rate or reoperation rate we'll be looking into. Again, it is a categorical one. So now what happens, right? the entire objective is to correctly identify the outcome measure. So if you correctly identify the outcome measure and you can identify which type it belongs to, then comes the summarization. So summarization is, yes, when I say categorization duration, I can use mean plus or minus standard deviation to summarize, or median plus interquartile range to summarize. How do I decide? So if mean and median are almost same, then in that case, what happens, right? We have an assumption called normality, and we use average value and the standard deviation for summarizing that particular variable. And mean and median is different, then we'll use the median and interquartile range for summarizing. And all categorical variables, we use frequency and percentage. So here now, if I see prostate cancer diagnosis, so I'll be using frequency and percentage, and later part now we'll be using a different name, sensitivity, positive predictive value. It depends upon the prognosis or the diagnostic characteristics we are looking at. And if you're looking for time to recurrence, so normally, right, any variable which is measured in time, we'll be using median and interquartile range to summarize. And which treatment has fewer complication, then no, we'll be using again the frequency and percentage to this one. Complication rate will be using. So the primary thing is in your PICO population intervention and the comparison and outcome. O is there, right? That O decides the what summary measures you will be using. So if I as I mentioned, the outcome is numerical, then we use the first one. The outcome is categorical, we use frequency and percentage, and outcome is numerical and having a lot of extreme observation, then we use median and interquartile range. So next step is, we won't stop there, we'll be comparing between the two groups. Say for example, this question, if I see, I want to see that the first treatment is better than the other. So outcome variable is catheterization duration. So I want to check whether catheterization duration in one group is more or less as compared to other. So I'll be using this summary measure. So my comparison will be in terms of whether the average value in one group is more or less in other group, or the median is in one group is more or less in as compared to others it is. So if the categorical variables, I want to see that whether the percentage of one particular characteristics or maybe complication rate, if I take, whether it is same as compared to in one group as compared to other group. So if it's time to recurrence, I will be like to see that whether the median time to event is same in one group as compared to others. So there are different types of statistical research questions it comes depending upon the summary measures we will use, and appropriately I'll choose a statistical test. So independent sample t-test I'll use when I'm comparing the medians between two groups. Mann-Whitney U-test if I use if I'm comparing the median. Chi-square test we'll use if I use comparing the frequency and percentage between the two groups. Time to recurrence, the median, if you see, normally we use log rank test for comparing the median survival time. And again, if it is a complication rate, it's a chi-square test and Fisher's exact test. At the end, I'll show some dummy table how the things have been presented. It is. So all this one, it starts with only one particular thing called outcome. So once you decide the outcome, then the second thing is we'll be looking into descriptive statistics, which measure we'll be using, and appropriately the statistical test will be used. So it's a comparison. I had taken only two group comparison. More than two group comparison also we have methods. And again, it depends upon whether you are comparing the mean, median, or percentages. So mean, if I'm using, I'll be using ANOVA. Median, again, there's a non-parametric version of that is there. And if it's a percent I'm comparing, I again will be using a chi-square test. Now, the analysis will not end here. So, for example, here I am comparing the catheterization duration between two arms. It is. So I got the first group is having 1.2 days less duration as compared to second group. And there is something called 95% confidence interval, which will give the range for the difference. I am observing a difference between two groups in terms of mean or proportion. It is mandatory that you have to give the range. I'm going to say it will give a proper idea about how the population the mean difference will vary. So in this case, we see I got a 95% confidence interval minus 1.8 to 0.6. So what actually it mean to say? So here we say that yes, we are 95% confident that the true reduction lies in between 0.6 to 1.8 days. So it is mandatory that whenever you are reporting, the effect size here is the difference in mean. We are going to take that. That's what we call as effect size. You have to report the 95% confidence interval. Further, what we do to see that yes, I want to have the independent effect of that treatment on the outcome variable. So we use a technique called multiple linear regression, which will adjust for the effect of all the confounding factors. We call it as confounding factors. I would say age, then you have taken prostate volume or all comorbidities. I'll control for that one. I want to see how much is the independent effect of this group. So for that, now we use something called multiple linear regression, and I'll get this effect size. So after adjusting, now I'll say that the difference is 1.2 days. Now it is categorical outcome variable. I said that we'll be using frequency and percentages. Later part, I'll use effect size called odds ratio. So here, no, this example, I got it 2.8. So what actually it is that, so odds of this thing, what to say, elevated PSA is 2.8 times in one group as compared to other groups. So I got 95% CI also given it is 1.6 to 4.9. So we can say that our elevated PSA have between 1.6 and 4.9 times of prostate cancer. So the 2.8 is what we say, the who has elevated PSA value will have 2.8 times chance of getting prostate cancer as compared to normal PSA level. So PSA level has been categorized like normal and elevated, and we'll be comparing the chance. So this we call it as odds ratio. It's the effect size. And again, I had given the 95% CI. And further, what we do now, we use a technique called logistic regression, which is we'll give the adjusted odds ratio, which will adjust for all other factors which is there in the model. Now, if I'm looking for a recurrence or survival time to event, we use some survival analysis where no, instead of odds ratio, I use something called hazard ratio. Interpretation is same. So if you see, I had one example. Patient with positive surgical margins have 2.1 hazard of recurrence as compared to with a negative margin. So I have two groups. Exposure is positive surgical margins, and this thing negative margins is there. So I'm comparing what is the hazard of recurrence it is. And here also I had given the 95% CI. I mean to say the population hazard ratio ranges from 1.3 to 3.4. So how do we interpret? We say that yes, this if I use Cox regression, I get the adjusted estimate. So adjusted for all other variables, what is the independent contribution of this particular variable on the outcome variable? Okay, and these are the templates for reporting. So if I have categorical variables, outcome has to be taken in the columns, and all the exposure has to be taken in the rows. And these are the frequency, and percentage has to be reported with 1 decimal places. And this is a p-value. So what do you mean by p-value? P-value is nothing but I'm looking for a difference in mean, difference in median, or difference in percentages. So we are trying to see whether the difference observed was statistically significant. So if a p-value is less than 0.05, then we say that the difference, whatever you observed in the effect size, the difference in mean, median, proportion, even odds ratio, hazard ratio, these are the effect size. We are trying to see whether it is statistically significant or not. So whenever you have a categorical variable, you have to represent this table in this format, and XS is the number I just mentioned. If it is mean, I'm comparing. So average value has to be given here with 2 decimal places, standard deviation with only 1 decimal places, and p-value, we'll be reporting here. And again, what we are comparing how much is the difference is there in the average values. And p-value is less than 0.05, we say that whether the difference is statistically significant or not. So these are all the variables I had just taken. Now, finally, right, if you are looking for some effect sizes, I can have frequency and percentage. And here we have to give the odds ratio. I would say the effect size. So here, no, the effect size I had given it as odds ratio. There is something called reference compared. So I made a statement in before, as compared to one group, what is the odds of event in other group? So that group will give it as 1, and what are the odds ratio I'll get it? I have to give the odds ratio with the 95% confidence interval it is, right? So we discussed about what is the type of outcome variable, how to summarize it, what do you mean by 95% CI, and what is the interpretation of p-value. And the last important thing is, sometimes you find a difference. So the difference, maybe huge difference will be there, and p-value will not be significant. Say, for example, here, I had observed the pulse rate difference, maybe some 100 units, and p-value I got it as 0.45. Actually, what happens? So there is a concept of power. Power means it says that whether you have sufficient sample to detect the difference, whether the test has sufficient power to detect the difference. So the power of a test is nothing but, yes, how good is a test to detect the difference, whether it is 70% powerful, 80% powerful, or 90% powerful. And it all depends upon the sample size. Anyway, there is one more speaker who is going to talk about the importance of sample size calculation. So whenever you calculate sample size calculation, we should ensure that there is some power in place, 80% or something will take, and accordingly we plan for a study, so that when you at the end you compare the outcome measure between group 1 and group 2, you will be the difference will be statistically significant. So and conclusion, yes, biostatistics, it plays an important role in generating evidence. Okay, and the main thing is that O, you have to remember PICO. The first speaker has mentioned about that. That O, you have to be very clear how it is measured, whether it is numerical, categorical, or yes, if it is something like time to event we are trying to have. And accordingly, your summary measure, statistical test, and the appropriate analysis will we will be choosing. And effect size and 95% confidence. Effect size means here difference in mean, difference in proportion, difference in median, odds ratio, hazard ratio. These we call as effect size, which you should have a clear idea, because later part when a speaker talks about systematic review and meta-analysis, they are going to use this thing. So you have to have a clear reporting of effect size and 95% confidence interval with p-value you have to report, so that your interpretation will be much more useful. And appropriate statistical methods, by choosing that, it will improve the quality of research, clinical decision making, and scientific publication. A good planned study and the problem is very novel, then always know the publication will be very easy. And if the objectives are very poorly planned and the sample size and analysis is not that correct, then the publication quality will not be that good. So this is what I have from me. So I'm ready to take questions at the end. Yes.
Well, thank you, sir. Generally, when we think about listening from biostatistician, we are very afraid because we think that the topic would be very complicated. You made it very simple. You made it understand from surgeon's point of view, and especially those dummy tables, they are useful for all the people who are doing the new research. They understand this topic. People should understand the type of data, normal, not normal, which test to use. You may not finally do all the biostatistics yourself, but you should actually know the concept as to what is being implied at what point. Now, understanding that the basics of biostatistics, as there is a level of evidence in research, one of the very high level of evidence is an RCT, randomized control trial, which has very high acceptance in any good journal. For this, we have Ginil Kumar sir, who is professor and head Department of Uro-Oncology at Amrita Institute of Medical Science and Kochi, and he is chairman of Collaborative Research Cell of USI. May I welcome you, sir, for this talk of designing an RCT, which is very important in medical research.
Am I audible?
Yes, you're audible and visible.
Thank you, Abhijit. Thank you, Surya. Thank you, USI. So, designing a randomized control trial, this is very important because nowadays, you cannot go with a case report to a journal because majority of the low-level evidence papers may be rejected. So, it is very important to progress to a level of RCT, probably, I will say. And we are afraid of planning RCT because of a lot of factors, and majority of the thesis will not be based on a RCT, but it's very important. Why RCT is important? Because this is the best form of evidence synthesis or a study where a bias is avoided by putting our putting the studying material in different groups, or we are actually, what we are doing, we are distributing the subjects into different groups in such a way that there is no bias happening. And this is the best way to identify the causality, whether this particular particular factor causes the disease or whatever you are studying. What we do is we have clear protocols by which external factors are not going to affect our study. How we are doing, we will study in this presentation. This has got in the hierarchy of evidence, this has got position just below the systematic reviews, and this is the best form of identifying a relation between the effect between the different factors, whether the issue is causing the disease. As Ravi has rightly told, most important thing is to identify a good research question. How you have to find a research question? You have to have a curiosity. You have to involve in your daily clinical work, so that few of the areas where you will find some gap. And one question you can create with all these factors, it should be feasible, because if it is not possible in your institute or in your population, don't take that question. It should be interesting, otherwise it may not get published. It should be novel. It should be having some credibility. It should be ethical and should be relevant to this time and to this place. These are the factors you have to consider when you are planning a research question, which is very important in a randomized trial. Otherwise, all your effort will be wasted. As Ravi rightly, the second thing is a PICOT. This again, I am repeating because this is very important. One, which are the population you are studying, you have to define initially itself. You cannot change in between. And all the factors, you have to make a framework, including the intervention, what you are going to apply to the two groups you are studying or two or more groups you are studying. Then you have to compare, and how you are comparing. When you are comparing, what is the outcome? As I was rightly telling about, outcome is the most important thing. You have to plan it initially itself. And within how many period you are going to finish that, or you are going to assess the outcome. These should be there clearly mentioned or planned before you go for a study. So suppose you are having a study, you have to have a population defined, like a prostate cancer or something. Then in this format, in the PICOT, we are analyzing AI-based MRI analysis and a clinician-based MRI analysis. And outcome, you can have a detection of Gleason rate 2+, or like a complication rate of biopsy based on MRI or something like that. And then the follow-up period, how much you are to get. All these things should be there in the question. And a little bit about the power calculation. So if you're planning a study, most important two aspects are whether you are creating a significant outcome, or second is actually whether you are so significance means if you have got a false positive interpretation or outcome, then it can be dangerous for the society. If you are having a study and if you are actually your drug, suppose you are having a drug, it is not causing a effect, and you are falsely telling that it is causing it is better, it can be dangerous for the society. So this is one factor we have to avoid, and this is by significance. You are identifying that. Second is the power of study. If your study is positive, and sometimes you may be you may tell that it is negative. So this is avoided by calculating adequate, by having adequate power, you can avoid this factor. So significance and power, these two factors has to be assessed, should be calculated properly. So the effect size, there should be a minimum number of patients you are studying, and you have to give a small number for the attrition rate. So should we have more number of what is required actually is unethical. If you want only 250 patients, and if you are planning to have 500 patients, you are unnecessarily causing intervention for 250 patients. That is not required, or can be. If the study is causing some bad effects, it can be dangerous. So you have to assess the power of the study, and you need not go beyond what is required. So before you plan for a study, you have to make a protocol. Protocol should have everything. It is like a master blueprint. You should design the methodology. What should be the statistical analysis you have to plan? All the ethical considerations should be discussed. And if there is any mid deviation or something is planned, like a crossover or something is planned, that should be there. And there should be, it is based on which the regulatory bodies validate your findings or give clearance for your study. So the protocol is very important. Next, you have to sit together. So when you are planning for a randomized study, there is one group. One thing is your patients, then the investigator, and there should be another person who is actually observing or monitoring the study. Usually it can be a statistician or somebody who is monitoring the study. Why this is important? Because you should not have an error, systematic error, by which your study go flop. So you sit with your department, you get a guidance from your head of the department or senior doctor, analyze completely the research question you are planning to analyze. Then how you have to do the study, you sit with a statistician, then plan what should be the methodology, then again reanalysis. Before you start the study, you have to iron out all the factors that could produce flop in the study. That finally gives you the best outcome and best paper for publication. So once you have that, you have to submit in the ethics committee, get a clearance. It should be, unless it is ethically clear, it will be very difficult to progress further. And since it is a prospective study, you have to register in a CTRI registry. Otherwise, later, there can be difficulty for publishing the study. Then you have to, if it is a multi-center, you have to initiate the site, discuss the study with different people, see who is going to take up the study there. Then you have to start the patient enrollment. So CTRI registration is very important nowadays. So you have to go for CTRI registration after ethics committee approval. So this is the website. You can create your own password and username and register. It is free of cost for individual registrants. So now after this thing, next phase is the randomization techniques. So different randomization techniques are, one is just a simple by just putting a coin and putting tail and heads. But the problem is sometimes tail can come for 3-4 people, and then one head will come again, tail can come for 3-4 people. So if you are going the simple randomization like a coin toss, the distribution of patients may not be uniform. So second thing is a block randomization. You keep it into 2 blocks and randomize in these 2. This is the best way to randomize. Or you can have a stratified randomization, like between different status, like less than 50 age or more than 50 age, have different stratifications, and then having groups in different stratas. Or cluster randomization is actually like you have one treatment in one cluster, again second treatment in another cluster, and you randomize these clusters. This is cluster randomization. Adaptive randomization, against if you are seeing that one treatment is better, you can change the allotment, like from 1:1, you can have a 2:1 or 4:1 if one study is finding it to be better. So these are all different style of randomization, which is very important. Then you conceal the randomization and give to the person who is implementing or investigator in a concealed way. And how we do is usually centralized randomization using a computer. You automate or with a registry in some of the international studies, we automate the randomization. And simple method is to have a sealed envelope, and another person is giving to you. But this is every chance that sometimes it can be manipulated. Another term you have to know is intention to treat. So whoever patient is randomized has to undergo the analysis. If it is per protocol, then you analyzing only patients who has followed up the protocol. Actually, ITT is better. So then you blind this patients. So single blind means only patient is not knowing who is having the treatment. The doctor will be knowing. Double blind, only the trial coordinator or the third person, probably a statistician or trial coordinator in your group, he is only knowing, and the doctor and the patient doesn't know what is the treatment given. In triple blind, even the trial coordinator is not knowing about the thing. Usually it is a double blind study we have. And most important thing is there should be a structural, there should be a defense system by avoiding any structural, avoid any structural bias, like the allocation has to be concealed, and there should be a security that this concealment is not opened up, and there should be a blinding. So all this is goes this is actually gives a security for avoiding a bias.
So sorry to interrupt, sir. Can we summarize, sir?
Yeah. So so this is called these are the different thing, and you have to go publish the thing according to consort protocol. This is available in the net. And I want to just tell that if you want to have a collaborative research, we have got an option now under the Urological Society of India. You can have multi-institutional collaborative study, and this is actually a data collection software we are making. So it is you are very important because your studies may improve the research culture in our country. So junior researchers has to come forward. Thank you.
Well, thank you, sir, for simplifying RCT, a difficult topic, in such a simpler way. Now, the pinnacle of any medical evidence is systemic review and meta-analysis. May I invite Dr. Aditya Prakash Sharma, who is additional professor at PJ Chandigarh, for this talk. Over to you, Aditya.
Thank you so much, Abhijit, Surya sir. Am I audible?
Yes.
And thank you, USI, for this opportunity. Let me go full screen. After that wonderful talk on RCT by Ginil sir, let's try to understand in the next 12 minutes what systematic review and meta-analysis are needed for, and how to read them and how to maybe kind of do them, but that is a workshop in itself. Just a sec. So why do we need systematic reviews? Primarily because as a resident or as a young clinicians, we are busy with our surgeries, with daily clinical work, and the medical literature is piling up. Almost more than 2 million biomedical articles are published yearly, and that rose exponentially during COVID-19. And no clinician can actually keep up with all the evidences. A lot of randomized control trials are being published day in, day night. So systematic review synthesizes all the available evidence, whether it's observational studies, RCTs, or whatever quasi-randomized studies, or whatever names, fancy names you can think of. And that gives you a unbiased, support-based, evidence-based practice. And when you look at the pyramid of levels of evidence, you find that systematic review and of randomized control trial along with meta-analysis is sitting at level of evidence 1A. And when you are asked on your rounds, the residents are asked on the rounds, you quote those EAU guidelines, AUA guidelines, and now we are coming up with USI guidelines. They all seek help from these systematic reviews to synthesize evidence and give a grade of recommendation. Although in our clinical practice, as at the fag end of the career, what we resort, and majority of our seniors also resort, is on expert opinion, which is level 5 evidence, and which I actually sometimes comes in handy in a lot of situations. But coming to the question why these answers cannot be obtained from narrative review, which are simply written, they are kind of a commentary. So as Ravi sir has mentioned, that your question had to be very specific based on PICO format. The narrative review, on the other hand, is just a broad question. The search is selective. Suppose I am writing a narrative review on, let's say, metastatic prostate cancer. So I'll include the studies which I think are relevant, and will be leaving out the studies which are actually much more relevant for giving me the correct evidence. So systematic review, on the contrary, gives you, after a comprehensive search, use explicit methods which are reproducible. So if I want to create a hummus, this is kind of a ingredients are going to be same, and if you are using it in the same proportion, whether at PGI, whether at AIIMS New Delhi, whether at MPUH, USI, CRC, or Harvard, you are going to get the same results and same outcomes. So objective of this particular talk are twofold. Primarily is how to read a systematic review, and by the side it's how to do. There are a lot of workshops conducted on how to do one. One is done at CMC Vellore, other at PGI for their own faculty members, and USI also I think will be going on and conducting how to do systematic reviews during UCCon and whatnot. So this is basic skeleton of a systematic review. You have a clinical question which should be very clear, as we have understood, for either of your study and also for systematic review. You have a PICO format, And as you register a RCT for CTRI, your registration should be done in Prospero, which is a free registry managed by NIH. And this gives you two answers. One, whether any ongoing systematic review is going on the same topic. Second, you are able to register this thing a priori so that nobody else is going to do it. And you can continue this study for over a period of 6 months to 1 year where you are able to conclude it. Then you do a comprehensive search based on your databases. Most common database used are PubMed, Embase, Scopus, Web of Science, and Cochrane Library. You do a screening. Then subsequently you do a literature data extraction, risk of biases assessed, evidence synthesis is done. And when you have similar studies, they can be combined as meta-analysis. And as Vasudev sir was telling you about, effect size and confidence interval need to be carried out. So let's understand it with simple questions. For example, I want to understand whether robotic assistance is better than laparoscopic approach for localized CA prostate in preserving urinary continence. So for this particular set, my questions for population is localized CA prostate, intervention being robot assisted radical prostatectomy, comparison being a laparoscopic arm, and outcome being continence primarily. You can have secondary outcomes also, let's say blood loss, you can have erectile dysfunction and so on and so forth. But you need to have a primary outcome which comes clearly in your question. This is a systematic review which we did in 2021, which was safety and efficacy of bipolar versus monopolar transurethral resection of bladder tumor. So for me, the question is clear. I am testing bipolar TURP against monopolar TURBT for patients with bladder tumor. So population being bladder tumor, intervention being bipolar TURBT compared with a monopolar TURBT, and safety and efficacy in terms of obturator jerk or bladder perforation was tested. Then we go to the literature search. The objective of this literature search is to do a comprehensive, transparent, and reproducible search. So you use mesh terms, you use free loaded terms, and you have PubMed, which give you mining of these terminology, which can be used and combined. So most common databases, as I mentioned, I personally use PubMed, Embase, Scopus, and Web of Science. These 4 databases for all my systematic reviews. You identify published and unpublished studies also. So you need to look at the gray literature, which is like you need to look for conference abstracts, trial registries, and you need to repeatedly send mail, at least 2 mails to the authors, asking them to give you raw data so that you are not leaving out any stone unturned to get data from all possible sources. Search strategies used during mesh terms, free text terms, using operators and or not. So for example, our previous question was on whether robotic assisted prostatectomy is better than laparoscopic prostatectomy. So we have keywords like prostate cancer combined with a operator or prostatic neoplasm, and robot assisted or robotic surgery and laparoscopy. And it is very important that you save this search strategy at upfront, and so that at any point of time you are getting the results are again at that particular date are mimicked by whosoever is searching that. So for our TURBT one, we had TURBT or transurethral resection of bladder tumor and bipolar and monopolar, and you can have a different strategy, but that strategy has to be published a priori in Prospero. Once you have done a literature search, then you need to do wheat from chaff. So you need to get your wheat and the chaff is to be out. You identify the studies which are relevant to you. You remove duplicates, you screen titles, abstracts. Then you do a full text review to do a data extraction and include primarily few studies which are relevant to you based upon the biases and the data extracted and a likable studies for meta-analysis. Data extraction is primarily performed independently by at least 2 reviewers with 1 arbitrator. You collect all the patient demographics, study characteristics, intervention and comparator, including all the data sets which Dr. Vasudeva was talking about, means, standard deviation, hazard ratio, odds ratio, and you can use standard extraction forms. So the first PDE5 inhibitor for stent-related symptoms, when we got 3 studies finally, and we did it using manually. So we extracted all the data manually because we were not sure whether we will be missing out on anything, and then we uploaded it to the Excel. And then you have a trails of mail to the collaborators. As Sir has shown, you can sit with the collaborators, but now you have Zoom and all those things. So you'll have to have a timeline in which you are going to do it. And now there are a lot of softwares like Revman is there. I'll just briefly touch upon it. that it's a wonderful review manager from Cochrane. It was free of cost till 2022. But if you are still doing a Cochrane review, it is free for you. And for a low and middle income countries, it's free. So if you have extracted your data, you put your data in, it will do everything for you. It will calculate the risk of bias assessment. You'll get your forest plot, you'll get your summary tables, and it will apply fixed effect, random effect analysis and whatnot. But now, since it's not free, you might have to learn R or Stata yourself, or collaborate with somebody who is very well conversant with R or Stata, like probably Professor Vasudeva. Then you look at risk of bias of the individual studies. As sir was telling, there are a lot of checks and balances. So those checks are to be checked again in this, whether your study conduction or included studies conducted very well. So you look for the randomization process, whether clearly mentioned, allocation concealment was there or not, participants were blinded or not. It is very difficult to blind participant or surgeon in surgical trials. So that is one gray area which surgical trials are there. Any missing outcome data, selective reporting, or other source of bias, and you mark them as per your red signal, yellow signal, and green signal as low risk, some concern, or high risk. And that is where your quality of meta-analysis is assessed. So another thing is publication bias. That was individual trial bias, but there are sometimes you must understand that only the positive studies are more likely to be published. We recently conducted a study on optical internal ureterotomy with amniotic membrane, but it came out to be negative. So it becomes very difficult to publish a negative trial, and that is called as publication bias. So when you have a funnel plot, you can see this funnel plot will answer. If you have a symmetrical funnel plot, it means that you have included predominantly all the studies. But if it's a asymmetrical, then it means that there is a possible publication bias, and that is what absence of evidence is not equal to evidence of absence. You must understand that. Once you have done this, now your data is ready for meta-analysis. Now you are pooling the comparable studies for greater precision, increased power, but you must understand two things, that it's garbage in, garbage out. I'll give you an example, and the second thing you need to look as heterogeneity. So my job is in next 2 minutes is to teach you how to read a forest plot. The forest plot has a square, a horizontal line, a vertical line, a diamond. How to read it, something like this you will get once you are done with your Rebman or you are reading a systematic review. On the left hand side of the screen, you see the included studies. You have outcome of study, each study in the middle, where you have experimental arm, control arm, and you have weight of each study, how much it is contributing based upon the events and the total number of patients. Then you have the effect size or the risk ratio and confidence interval, and that is what is reflected in the forest plot. So if you look at each square here, it will give you the outcome or effect ratio from each single study along with the confidence interval. And this is the line of no effect, and this is the pooled data, overall effect. When overall effect is touching the line or crossing the line, it means the data is not significant. Another thing is very important, you need to look at the bottom of the table, is the I-square. This is the proportion of variability that stems from heterogeneity. And when you look at this I-square, if it is 0 to 25%, it's low heterogeneity. If 25 to 50, it's moderate. And this is acceptable heterogeneity. Higher the heterogeneity, you need to go for random effects, or you need to get it over altogether from the meta-analysis. This heterogeneity primarily arises from difference in population, intervention, outcomes, and study designs. Another important thing I just want to mention is garbage in, garbage out. Sometimes what happens, if you look at systematic review, I was giving a talk on antibiotic prophylaxis in perioperative period for PCNL. And I came across this systematic review. You look at these two studies, the data set is exact same. In next meta-analysis also, it is also exact same. And if you look at the pooled weight, it is almost combined 42% of the weight to this diamond, which is driving this diamond towards the left, that antibiotic prophylaxis in perioperative period is useful. Why this arises is because of the salami slicing. In 2011, the group has published in 2011 one RCTs, and again in 2012, maybe some more patients were taken, and it is again published. So as a author and as a researcher, you need to understand this point. You need to analyze the systematic review and meta-analysis with these facet and see whether it is applicable or not. So to summarize, you identify the issue, determine the question, write a plan, search for the study. You select your studies, extract the data, combine the data, do a meta-analysis, and go ahead. So whenever you are doing a meta-analysis, you see for these things, protocol is registered, you do a comprehensive search, there are independent reviewers, risk of bias is assessed, and appropriate synthesis and heterogeneity has been explored. So my take home are a systematic review minimizes bias and hence it is reproducible. Meta-analysis increases precision, not the study quality. Be wary of the heterogeneity and the biases. Always check Prisma, forest plot, risk of bias, and I-square. Start with a crystal clear PCOG format question. Build a team of like-minded individuals who are interested. Divide the work and stick to timelines so that you are able to finish in 6 months to 12 months. Thank you so much for your patient hearing. This is the resource material which you can carry and go ahead and do your systematic reviews and meta-analysis. Thank you.
Thank you, Dr. Aditya, for such wonderful summarization of how to do a systematic review, generally a difficult topic to understand. Now, once we understand there are various studies, the most important crux of any biostatistics or study research is to choose the right sample size for the study. And this is where majority of so this topic would be very important for all the residents who are starting the thesis. For this, may I welcome Dr. Pankaj Maheshwari, who is Chairman of Urology at Fortis Hospital, Mulund. Over to you, sir.
Am I audible?
Yes, sir. You're audible, sir. You're visible
Yeah,
also.
I have kept my video off because I'm traveling.
Yes, sir.
I sincerely thank ISU and USI for this kind invitation. Friends, today, instead of talking about how to calculate sample size, I would predominantly restrict or stress more on why sample size calculation is needed. I've been attached with Indian Journal of Urology for more than 2.5 decades. For a major part of this 2.5 decades, I was there as an author, potential author. Then I joined the team of reviewers, and today I'm there as an associate editor. In my initial days, I suffered because a lot of my studies was rejected because my sample size calculation was incorrect. Then came a period when I understood these intricacies. I became a reviewer, and then I started critiquing as an associate editor. When I send back any study to the editor saying that study needs to be rejected because sample size is not good, the rejection happens immediately. Otherwise, the editor probably looks at the study in more details before rejecting it. So what this means is that sample size calculation is one of the most important thing that a reviewer of a study would look at, because undoubtedly it's the basic of every study and a basic. You want to publish sample discussion needs to be mentioned in the method or your checklist. And if you want any of your studies to say get a IRB approval or the funding, then again sample size calculation becomes extremely important. Friends, remember that sample size needs to be calculated before you start the study. Gone are the days when we would collect the data, look at what we find in the data, and then try to make a study out of it. That is absolutely not acceptable. If I have a very large sample size, my error is likely to be less, the precision is likely to be more, the power of the study is likely to be better. But this may not be ethically acceptable in a lot of situations. Say I'm trying a new surgery, I'm trying a new drug. I can't be putting a large population at risk just because I want a large sample size. Small sample size is okay for rare diseases, but small sample size is likely to produce false results. Let's take a small example. I stay in this society with 8 towers. There are around 1,800 flats and approximately 10,000 residents. Now I want to find out what is the incidence of smoking in my residential society higher than the city of Mumbai? What are my options? One option is I do a consensus of every member of my society. Obviously, this is going to be a huge effort, big manpower needed, time consuming and expensive, may be practically impossible to achieve. So what I can do is choose 500 out of these 10,000 people, analyze them, and then extrapolate this to the 10,000 population. This probably is doable and would be nearly approximate of what the full society would have. Suppose I want to cut corners and use a very small sample size. If I choose, say, a sample size of just 10 people, it is possible that either none of those 10 are smoking or 8 of those 10 are smoking. So again, my results would go wrong. Choose sample size them, I may find people who are, say, health conscious and non-smokers. If I go to party hall, I may have people more likely to be smokers. So overall, my sample size should be representative of population and not a part of population. So just take this example. The gray area is the full population that I want to analyze. If I take sample 1, which is skewed towards one side of the population, though the sample size is good, because it is skewed to one side, I will not get a good data. Sample 3 is small and again skewed to one side. What I am looking at probably is sample 2 to get a good sampling of the full population. Why do we want sample size calculation? There are two simple errors, or two errors that can happen in any. We don't. So these are the two we want to minimize. These two errors are given name of alpha and power. There is a finding there is the possibility of me not finding that day. So what is the possibility of risk of rejecting the hypothesis? I want to so power is
Audio is not clear.
I think Dr. Pankaj sir.
Maybe it's not getting signal there.
I think yes. Dr. Pankaj sir, are you audible, sir?
I logged out. I didn't realize.
So, sir, let me share the screen because you will that will eat away your bandwidth. I will do the slideshow, sir. Is the slides are the slides visible to you, sir? Pankaj, sir. Okay.
You lost him.
Okay. I think, sir.
Will you take the next talk?
Yeah, we'll take this next talk, sir. Yes, sir. One of the most tedious one of the most tedious job in writing a paper or writing a thesis is obviously managing the bibliography. This is where everybody gets irritated, and especially managing it when you want to edit the manuscript. For this, may I welcome Dr. Prashant Muralkar, sir, who is a consultant urologist at Tirthankar Hospital, Akola, Maharashtra. Over to you, sir.
My slides are visible, I think.
Yes, sir. Can you use the slideshow, sir? The option right. Use.
I'm already using slideshow. It's not there.
We can see. Yes, sir. You
can
can
see the-
click this button of use slideshow, sir. The
Wait,
four.
just a.
Yeah.
Actually, I was already using slideshow. Wait, just a minute. I'll end the show. Can you see the slideshow now?
No, sir.
Okay. What I will do is I'll.
Yes, sir. Now
Yeah.
it is. Yes, sir.
You can see my slides.
Yes, sir.
Organizing bibliography. That's there, na?
Yes, sir. Yes, sir.
Okay. So, friends, doing research is very difficult. Only thing, the reading, the research, and writing it should be made easy. And for that purpose, we have this software, which are bibliography management software. So I am going to cover myself as a person who consumes research, as a person who organizes research, and as a person who creates research, or who creates the manuscripts. So as a consumer, I'll be reading. As an organizer, I'll be keeping the data in a proper place. And as a creator of research, I'll be writing the manuscript with proper references. So for that, I have got different softwares, which are Zotero, Mendeley, EndNote, and Paperpile. These are the main software that are being used. Previously, the most commonly used one was the Mendeley, but it has now become paid software. So the most common software that is being used is Zotero, used by most of the students, consultants, and of course, institutes which are big institutes use EndNote. And if you are a Google Doc user, that means many people are working on the same project at the same time. Paperpile is the software to be used. I'll be focusing mainly on Zotero. So as a consumer, organizer, and creator of the research. As a consumer of the research, I'll be using Zotero to manage my references, store the references, maybe books, articles, reports, web pages, even movies and audio files. And I'll be organizing these with a field called as metadata. So Zotero is to be installed from the web as a standalone software. You have to also have a Zotero connector for the Chrome or any the web software that you are using, and you have to also have a plugin for Word. Now, this is how the Chrome extension on the Zotero will look like. So any article that you are reading on PubMed can be saved to Zotero just by click of this Chrome extension. So what I do is, whenever I search a PubMed, I save it directly to the Zotero and add tags to it. Maybe say if it is a paper on PCNL, maybe a paper on BPH, maybe also it's a guideline or something to be done to be used as a research methodology. In my own practice, I have a habit of naming the paper after author, title, journal, and year. But the Zotero can store a paper automatically in its own directory or in its own folder system. I'm not using that because then you are become too much dependent on the software, and you really do not know what is going to happen to Zotero after a few years. Because last 5 to 6 years, I was using Mendeley, and whatever my collection were there in Mendeley, I'm not able to access. So I'm still using manual system of storing the research papers. One of the important part of Zotero is a PDF reader, which is incorporated in Zotero. You can underline the document, annotate, and these annotations will be tagged with your reference, and then they can use those annotations for importing in your document. Common mistakes is saving the file with numbers or maybe paper or something like that. There are many times we have duplicate. Many times we have got 5 to 6 copies of same document, which should not be there. So that is how I am as a consumer. I am an organizer of the research work. For that, what I am doing is I am using collections in the Zotero. Now these collections are for different types, for different keywords and different subtypes. Let's say we have a collection called kidney stone, then I have a subtype like PCNL, RIRS, and something like that. So this is how it will be there. On left side, these are the collections, and these are the different tags or keywords, something like a keyword. These are the tags that are attached to these research work, and this is the title. And on the right side, this what you are seeing is a metadata. That means the details of that reference are there. To retrieve the items in Zotero, because now I'm an organizer, I'll be using maybe title, year of publication, or when it was added, or maybe by author name, or even a keyword for that article. I'll be able to retrieve that article within seconds if I'm using this feature in the Zotero. Another important thing in Zotero is the relations. That means if you have got one presentation, same topic you write a book chapter, same topic you present at somewhere, same topic you have another research, everything can be related to each other by this relations feature in a Zotero. Of course, the duplicates can be merged by either title or by tag in Zotero. Now, when I'm writing a research paper, that means I'm a creator of a research work, I need not use Zotero, but it is better to use a software. Microsoft Word has got its own bibliography system, but it is not so easy to use. So to write a manuscript using a bibliography software, you need to have a plugin. This is the Zotero plugin for the Word, and this is bundled with the Zotero installation. And with this, you can add references. I'll be showing a demo of this within a minute. You can add references either with the author's name or by the topic or by journal or something like that, and you can make changes to the references. If something is wrong, you can change the proper journal name, proper page number, everything. And if you are doing a multi-author, now this is the problem where Zotero may not be very useful. If you are doing a multi-author work, you have to do editing turn by turn, and both the authors or many of the authors need to be using the Zotero desktop app installed in their computer. So for multi-author manuscript editing, it's not easy. The last feature that I'm going to discuss is unlink the citations. That means suppose my paper is accepted and there is some error in some reference. If I have to change it manually, then I have to unlink the citation. With this, I end this presentation and I'll be showing you a semi-live video. Now, is my video visible, Abhijit?
Yes, sir.
Yeah, I'll start. I think audio should come with it. Is it coming or not? Just a minute. I'll stop and do again, please. Just a minute.
Okay, sir.
It's a timed video. This I'll not exceed the time. No problem. Yeah. Yeah. The audio will be coming. Yeah. This is our demo manuscript. Wherever there are any references to be put, I have put red colored marker for easy identification. We are creating one collection in Zotero named after our topic, and to this collection we are adding the PDFs from the designated folder one by one. Zotero is creating metadata entries for all the references, but for one reference the metadata entry was not created. To add this item to Zotero, we are copying the title to Google Scholar, and there we will be creating the entry with bibtext. This is the article. We are creating a bibtext entry, and from that we will be manually creating the item in Zotero. All the fields from bibtext are manually copy pasted from bibtext to Zotero. We are now ready to add references to this Word file. Click Zotero, add reference, put cursor to the point where reference is required, select Vancouver, say OK, and then type the name of the author. The Zotero entry will come. Select the proper reference and tick mark yes. Our reference is added now. Here we have to add 5 references. Put cursor there, add reference, select references one by one. When all 5 are in the top row, tick yes. The 5 references are added. The remaining references are added one by one in similar technique. Taking cursor there, selecting a reference, tick yes. To add bibliography, go to Zotero and add bibliography. All references are now added. To change the reference style, go to document properties and select the style that is needed. This is required when your manuscript is transferred from one journal to other journal and the other journal requires document in different format. Before submission, we need to check if all the references are properly ordered and the journal details are properly given in the manuscript. Here we find that the fifth reference is not correctly depicted, it is incomplete. This is being corrected by manually changing the metadata of that reference from PubMed entry. Go to PubMed, click Cite and copy the required details from there and paste in Zotero. Once you click refresh, the changes that you made in the Zotero will be reflected in the Word document like this. If your manuscript is accepted and minor changes to the references are to be done, it is wise to unlink the citations and do changes manually. So thank you. That was the how we manage the bibliography system. Actually, it is a complete topic for 3 hours to see tell about Zotero, but I have covered how to write a manuscript.
Well, thank you, sir, for that wonderful presentation, because this is the most tedious part of any publication. I think you covered it very well, sir. Now, once everything is done, all your research has been done, the most important thing is to place it at a proper place. So we have to choose the right journal for all your efforts. And for this next talk, may I call upon Professor Arun Chawla, sir, who is Professor and Head of Department of Urology at KMC Manipal. Over to you, sir.
Thank you, Abhijit. Thank you. Let me just open my. Am I audible?
Yes, sir.
Okay, just let me see. Where is my. Is it seen? Is it there?
It's just saying it started sharing the screen, but we have not yet seen the screen, sir.
From my side, it is coming. Is it okay
Yes,
now?
now it is visible, sir.
Okay. Shall I put on the slideshow?
Yes, sir. Yes, sir.
Is it okay?
Yes, sir.
So thanks ISU USI for giving me the opportunity to be part of this very interesting webinar. Interest to the residents as well as the young urologists. And the topic given to me is the choice of a right journal, the journal which is suitable and appropriate to the study which you have done. We know there are a list of around 200 journals which are of urology or related to urology, which can publish your research. But how to find out which is okay for our study which we have done? One of the biggest reason our manuscripts get rejected is not because of poor science, but because they are sent to a wrong journal. So selecting the appropriate journal before submission is very important. It will increase acceptance. It will reduce the review time. Multiple rejections can be avoided, and you can improve your visibility of your work. The best manuscript or the best clinical study put into a script form in a wrong journal is still likely to be rejected. Why? Because different journals have different aims. They have different viewership, different readership, different acceptance rates, and different impact expectation. Editors, most of the editors of all the renowned journal ask themselves, is it scientifically good? Or is this paper appropriate for our readers? Because every editor of a journal knows is not the scientifically good, but whether it is good for the reader assigned to that journal. Now, before choosing a journal, ask yourself what type of work you have done. whether it was a properly planned randomized study, a prospective observation study, or it was just a collection of data put into a retrospective study, or you have taken one of a very rigorous systemic review and meta-analysis. Was it just a case report of a very interesting observation, or was it a study on a particular surgical technique which you have innovated, or your study was basic science on some animals or some other stuff? Why? Because different journals prefer different type of articles. If you see the different journals, there'll be few original articles, there'll be few meta-analysis, there'll be few devoted to the basic science, there'll be few devoted to the translational science. So each journal have a different section. So you have to just see that what type of study is I have completed and where I find the appropriate space for my study in the urology journals. We all know that it's very important that if you finish your clinical work, you are interested in knowing who should be reading your paper. Is it your work devoted to a particular specialty? Say it's a study on a urethral strictures. To whom it will be interested? It will be of interest to the reconstructive surgeons. A study on a long-term follow-up of the children with procedural valve, VUR, will be of interest to a different section of urologists. A study on stone and all that will be of interest to endourologists, or it is a study which is meant for general urologists. Say example, a paper on RA suction or without suction may be of interest to a particular type of journals, Journal of Endourology, World Journal of Urology, BJU International, more than the broad surgical journal in urology. Now, this is often the most overlooked step. When you have finished your work, you have written the manuscript and you are looking for the journal. Always very important, read the aims and the scope of the journal which you wish to submit on the journal website. Just ask and check whether this journal publish stone disease if you have a work on stone, robotics if you are publishing your result of a robotic procedure, if you have something related to brain dead transplant or live related transplant is related to those field, is a journal publishing those articles, or is it a journal devoted to function urology or uro-oncology? Many of the manuscripts get rejected from the editorial desk only because they are outside the journal scope only. It's very important that we always look at the aims and the scope on the journal website, which is very precisely mentioned on any journal, urology journal, which you plan to send your script. Now, it's a very best and effective trick which I utilize. Supposing I have done a clinical work, what I'll do is I like to take this clinical work and put it into the Google PubMed and see how many articles are similar to that in the already published journals. Now, let us assume I have taken a regional study on a laser, randomized study on the laser, thulium versus this. I'll see how many articles related to that work have been published in different journals. I'll not be taking the case reports or the narrative review or the systematic review. Then I will ask myself whether my study is related to the articles published in those journals. Was their methodology same? Was my sample size same? Or already people have done a work which was with much bigger sample and which much better analysis. Are they were close to my topic? If yes, that probably will be the few selected journal which I'll shortlist to send my manuscript. Because if you see, majority of our editors, they like a consistency in their journal articles. It's very important. You should not be obsessed about the impact factor. Many of the times we just look at the impact factor of a journal, but there are other important index which are to be kept in mind. Site score, the quartile score, the Q1 to Q1 classification of various journals. You may have a European journal in Q1, but you have a journal which is fitted to your manuscript is placed in Q2. That is, you have to choose now whether to go for Q1 or a Q2. You have to see where your audience and viewers are and what is going to be the acceptance rate. Very important message is a lower impact factor journal that reaches your work to the target audience is often a better choice. Remember, publishing is much better than endlessly chasing the prestige. I want to go in a Q1 journal. I want to go to European Urology. If it gets rejected, I'll come to American AUA journal, Journal of Urology. Then I'll come to BJU, and that's how I'll keep downing the ladder. That is not at all a great idea. It's very important. You should always keep in your mind the acceptance rate. It matters. If you have a high impact journal in your mind, just keep a very important impression that it has acceptance rate of 10 to 15. A mid tier will have 20 to 35%. Specialty journal have little more. And it is very important that you need to have a realistic journal in your mind, which can lead to faster publication than going for just the high impact journal and getting your manuscript rejected. Now, this is very important for the resident and the young urologist. In every journal site, there is a mention of the time to first decision, time to publication, online first publication, and then the final publication. There will be some journal which have impact factor at a lower side, but publish it within 8 to 10 weeks. That means less than 3 months. But there will be few journals which have impact factor of more than 5, 8, 10, 15, which may take 8 months. So is it worth it? Now, how does it affect? Supposing you have to go for a promotional interview, or supposing you have to apply for a fellowship, this becomes important. You need to get your work published as early as possible. And how you will go for that? You will look for, you will forget the impact factor, but you will have a little realistic view of your the time and the choice of the journal, so that your publication get accepted within the due period. Time does matter, for especially for the residents and the young urologists. So here you see an example of European urology. It is on their page only. They have written all the things. Impact factor is this, site score is this, submission to the first edition is 4 days, acceptance to publication is around 40 days. If you take another premier journal, BJU International, submission to the first issue 8 days, they will say whether it's gone to review or not, with acceptance rate at 20%, impact factor 4.1. So all this information you get from the journal site. Now, this is another angle. When you are looking for the choice of a journal for your script, there are different types of journal. Some give you a little easy way. There are open access journal. What is the advantage? Means it's very, very higher visibility. Means because it's open access, anybody can read it. And that's why, because it's well read, more visible, it gets more citations and immediately access for the publication. But the disadvantage is most of the open access journals charge very high article processing charges, very high. If you see in terms of Indian rupees, somewhere it costs from 2.5 to 7 lakhs even. So this becomes a little difficult for people who don't want to spend that much money for just getting their script into the publication form. Then there are subscription journals which are periodically, monthly or 3-monthly, which take a little longer time but have very lower publication cost. And then you have hybrid journals. Now, why I'm bringing this? There are certain institutions who are working as a faculty. If their institution has already got an open access agreement to the list of urology journals, you get an easy passage. You get that article processing charges covered under that agreement. So this gives many of the institutional faculty a little easy way of getting your work published, because whenever you have an open access, they do charge, though the time for the publication remain the same, the time for the review process is same, but little bit of easier passage in terms of open access as compared to the subscription charges. Never get tempted to publish your work in a non-indexed journal. Always look for journal indexed mainly with PubMed, Medline, Scopus, or Web of Science. All this index adds value and weight to your work which you have done over a period of 6 months, 1 year, or more than 1 year. In all the circumstances, avoid predatory journals. Now, this is the very important precaution, especially important for the young urologists and the residents. There will be journals who self-advertise, very fast acceptance. You will get all this information in your mails. If you go to their website, a very poor website, there's totally fake editorial board, and you will get all, if you open your spam mails, you will get almost 10 to 15 of these editorials for publication to their journals, and they guarantee publication. They will say speeded review 1 day, 2 day, 4 days, 1 week. But remember, if it sounds too good to be true, it probably is. So never fall prey to this. All these red flags should be in your mind when you have done a very good work. So my algorithm is, but how I plan my workflow. If I have done a study, I get my manuscript finished with the help of resident who has done the work. I'll see, what is the article type, whether I took a randomized study or whether it's a prospective observation study. Then I'll go and look at the similar paper published, and I'll see which are the journal which have published these type of studies. Then I'll compare my work with the other works, whether the other people who have published their work was better than mine, and what is the scope of the journal impact factor. APC gives me a little advantage because as a faculty of our institution, we have open access agreement with many journals, so including European Open Science, European Urology Focus, and many Springer. So this gives us a little bit of advantage. Again, after finishing this, I'll be going through the author guidelines very carefully, and then only I'll submit to avoid unnecessary rejection. This is a checklist which we keep it handy for publication when we have close to finalizing our manuscript, or we have finished our manuscript. I'll run through that. So this is a very important issue. Can I match my manuscript with the journal? Is there any way? Yes, you can do in many ways. You can go through PubMed and check how my manuscript will fit into a particular urology journal. Scopus helps. The journal citation reports. Elsevier Journal Finder is there. Springer Journal Suggester is there. Willy Journal Finder is there. There are many. But supposing you are going to Springer, they will tell their Springer journals. These are the journals. And even if you have sent to them, they will review, they will reject it, and then they can submit to the sister publication, 1, 2, 3. And if you are going for Elsevier and all that, you need to have a subscription, and probably login will be difficult without subscription. These tools are basically helpful based on your title and abstract. You submit to them, and they will give you the list of various journals suited to your abstract and title submitted. So let us assume I had one study, which was a randomized study on the use of thulium and holmium laser for the stones. I used the Elsevier Finder. I put the title and the abstract. I got the list of 40 journals. So I can go one by one of the 40 journals. I'll go to the journal site. I'll just see the guideline. I'll just see the instruction to the author. I'll see the impact factor. I'll see the study which have been published. I go through and then make a call. Other way which I feel more useful for me is I do the work. Supposing I had given a dissertation on a LUTS in the young man. So I'll go and in the PubMed I'll put LUTS young man to Boolean and try to see how many articles of similar type have been published. What type of studies have been already published? What sample sizes they used? What methodology has been used? For me, this gives a little better reliable way to identify journals which will be genuinely interested in the script which I'll be sending to them. I think with that,
sir.
yes,
Sorry,
sir.
sir, to interrupt, sir. Can we just summarize, sir?
Yes. This is the last now.
Yes,
So this is another way which is very easy. People have found out, my resident do sometimes. Now here you see, I have gone to the ChatGPT. This is a free. I won't go to ChatGPT Pro or 5 and all that. You see in ChatGPT, I have put the title first, and in this I have put the abstract, and I have given the prompt. Now what it has given is, it has given the strategy. It is say for your abstract which you have given with the title, WJU, BJU, J endourology, urotherapy are the best. Why they are best? Because it suits that. He has given his suggestion, and he has given the acceptance, the rate of acceptance. Then he has given the second option. that interventional urology, nephrology, maybe urology, investigative, current urology may be the backup option. He gives the third tier also you need to give, which have better chance of success than the tier 1 and tier 2. And it clearly says you avoid sending this script to European urology, focus, J urology, nature views, why, and all that. And this is coming to the conclusion, FAR, FAR. Find 5 papers closest to your script which you have finished, a study which you have finished. Where were they published? That journal becomes that journal, or journals become your starting point. Avoid submitting your script beyond the manuscript level. A retrospective study you can't compare with the multicentral RCCD which have been published in a Q1 or very premium journals. Always read instructions, do the matching, find out the structure of your script, word count and figure tables before submitting. To conclude, the correct journal before finalizing the manuscript is very important. You can match your manuscript with the journal scope and readership on the various sites, but always verify the journal manually. Keep in mind impact factor, indexing, review time, and publication cost. Don't take it as a sake of prestige. Follow author guidelines to prevent unnecessary desk rejections. Never submit to multiple journals at one time. Thank you very much.
Well, thank you, sir, for that wonderful talk, because this is where many of the young urologists and residents will make mistake, choosing the wrong journal. And since we are short of time, is there Pankaj Maheshwari, sir, are you there?
Yes, I'm there.
So we will try to, sir, summarize in 5 minutes, sir, about the talk, sir.
Okay, Vijit.
Yes, sir. Is it visible, sir, for you?
Yes, it is visible for me.
Yes, sir. Yes, sir.
So, friends, I really regret all the problem that has happened, but because I was traveling, the net connection was very poor. Coming back, once you choose the sample, why you are choosing a sample is that you want to avoid 2 types of errors. One error is where there is no difference, but we find a difference. Other error is where there is a difference, but we don't find a difference. Next, Abhijit.
Yes, sir.
These two are given 2 terms which are alpha and power. By alpha, we mean that we want the possibility of missing a difference to be less than 5%. So I want to set the alpha at less than 0.05. And by power, I mean there should be at least a 80% possibility of finding the finding which I am looking at. That will give me a power to my study. Next. So the power, as we have said, needs to be set at 80 to 90%. If the power is too low, then I would not get the desired result. If the power is too high, then the sample size will be very high. Next. We all understand significance level. We know that when the p-value is less than 0.05, we call it significant. What this means is that when the p-value is less than 0.05, there is a less than 5% chance that what the finding we have found is by chance and does not exist. So this gives the alpha of the study, which is the significance level. Next. How much sample size should we take? This is an extremely difficult decision. This always remains approximate. Obviously, we cannot assess every patient that comes to our OPD. Next. The aim is to have minimum number of subjects which give us a strong and robust conclusion. We also need to take into account our funding, manpower, logistics. It is no use trying to bite more than what we can chew. Next. There are various ways of sample calculation. We'll come to that later. Next. Remember that sample calculation is not standalone entity. It is not just numbers and formula. There is a lot to it. Next. Abhijit, next. First, I need to understand the population is we read. I need to have complete information about the population. I need to decide the power and the significance level and the statistical analysis that I would be applying. Next. The objective needs to be very clear. So it should be a quantitative. No, go back. Go back. This is creating problem. Yes. So no, yeah, just click just once. The objective needs to be very clear. We should have a measurable objective. So example that I give is that I want to determine the incidence of radiation protection among urologists. Now this is easy to do. The answer would be yes, no, or occasional. Next. But if I want to assess what is the perception of radiation protection, this would become difficult because not many factors would come into this. This would mean that my sample size would need to be really very, very high. Next. The hypothesis needs to be decided well. The statistical study that we would be using needs to be decided because the same statistical study would be used in calculating the sample size. Next. Effect size is what we are looking at. This is the smallest clinically important difference that is sought to be detected. Large samples are required if we are looking at smaller difference. Conventionally, we would want a 80% power and a less than 5% alpha. Next. The better way of calculating the effect size is we can do a literature review, look at the prior studies in the recent 5 years with a similar design, similar treatment, and similar patient characters, and take the help of those studies to calculate your sample size. Next. Or you can use historical data and apply that data to your population and get the sample size collected. If historical data and literature is not available, say you are doing a pilot study, then an educated guess or expert opinion can be done. Next. So to summarize, understand the objective, select the appropriate statistical analysis, calculate the estimated size. Go back, please. Go back. Then based on that, provide additional allowance for say non-responders or people who will get lost to follow-up, and then finally make a statement of your sample size calculation. Abhijit, I will stop here because I don't think we are really managing it.
Okay.
Sorry.
I think, thank you, sir, for making time out of it, sir. Can we have a last comment from Dr. Vasudev, sir, regarding this sample size? Is there a simpler formula for this, sir?
Chalo.
Yeah, I think there is a online tools are there. Say there are GitHub. There is one link is there where we can. I just posted in the chats. So it is readily. You have to just give the how much is the difference anticipated clinically significant difference and the required components we have to give it, and it will be easy for everyone to calculate the sample size and. Especially for the postgraduate thesis and all, yes, even though we calculate the sample size, there's a time bond is there and the very rare events also will be there. So all these things has to be looked into consideration and carefully that section has to be filled. I agree with that. Yes, we have to do power calculation and all, but many of times what happens, the funding and all is the issues. So normally what actually we do is we use the power calculation also followed by we use the feasibility also, we look for the time also. So among that, which one is better, that we'll go into that. And this is a very useful user-friendly tool. If you click on that one, it has all this one comparison of means, then proportions and all the things has been given. And anyone can try it. It is. I just posted the link. It is, yeah.
Thank you, sir. Thank you, sir. Ravi
Thank
Mohan,
you.
sir, there is a question. How would you frame a question for a new concept, sir?
How would you frame a question for a new concept? So for a new concept, again, you would have to have a comparator. So unless if somebody asks me specifically what new concept he wants to ask, see, because in my presentation, if you remember, one important thing was also that it should be ethical, that the patient cannot be compromised. So you cannot try something new concept. The best way would be that the question actually it requires a bilateral interaction to know what is the concept which is talking about so that we can answer it, because the new concept I don't know what is in his mind. But ideally we start with a pilot. So let's say we thought that can we do an early radical prostatectomy, the one which we did a couple of years back. So it was a new concept for us because the standard was 4 to 6 weeks after biopsy. what we did is we did a pilot study of 10 patients so that you know that, okay, this is feasible or not. And once you know that it is feasible, and then you go on to expand the study with respect to specific outcomes. So that would be one. Suppose you want to try a new drug or medication, then you can already have a, let's say, the stampede arms like you have. You have one standard comparator and against which you test the newer composition or a newer medication. So I'm not sure unless we have an interaction, I cannot go because it's an on and on answer.
Okay, sir.
Thank you.
Thank you, sir. Thank you, sir. Sorry, Surya Prakash, sir, we have shot slightly ahead of the time, but I think it has summarized the clinical
Yes.
research and biostatistics very well. Thank you, all the speakers, and over to you, Surya Prakash, sir.
Thank you, Dr. Abhijit. It was really a wonderful session, a unique session, I can say. I think this has to be seen by all the residents. It is recorded. It's a must for all the residents. Now, all the topics I can say, I can enumerate one by one. Dr. Ravi Mohan has very nicely, his slides were excellent. Point to the question, how to frame the research question. Thanks, Dr. Ravi Mohan, and Dr. Aditya Prakash very nicely summarized about systemic reviews, meta-analysis. Of course, there was some glitch in Dr. Pankaj Maheshwari, but it was well explained. Dr. Ginil, thanks for giving a wonderful talk on RCTs. And Dr. Prashant Malavkar, very nice video, very well explained about how to choose the bibliography. Dr. Vasudeva nicely summarized the biostatistics. And Dr. Arvind Chawla, a wonderful presentation on how to select the journal. Thanks, Abhijit, and thanks all the speakers. So I think I should see this session again and again. Wonderful. Thanks all the audience for joining. Thank you very much. Dr. Keshav, I think he's just left. Well, that's it. Thank you very much. We'll see you again.
Good night, sir. Thank you. Thank you, Abhijit.
Everybody.
Thank you, everyone. Thank you,
everyone,
sir.
for your invaluable time, sir. Thank you, sir. Thank you, Surya Prakash,
Bye.
sir. Thank you.